All right, welcome back to the deep dive. Today we're shifting gears a little bit.
Yeah, a lot.
We are definitely leaving the shallow end of the pool. Usually we take these big, broad topics and try to make them accessible for, for everyone.
Right.
But today we're putting on the white coats.
We're stepping right into the rounding room.
This is a Grand Rounds style deep dive, and we're tailoring this specifically for the hematology-oncology specialists.
That's right. So we're going to assume you know your way around a CBC. We're going to assume you've managed your fair share of platelet disorders.
And you don't need us to explain what a megakaryocyte is?
No,
Yep.
Absolutely not. We're skipping the introduction to thrombocytopenia 101 and jumping straight to the advanced class.
And the subject of our obsession today is Fostamatinib. You probably know it by its trade name, Tavalisse. It's a drug that's been on the market for a few years now, approved for chronic ITP, but I feel like for a lot of clinicians, it's a bit of a mystery.
It really is. It occupies this strange sort of nebulous space in the treatment algorithm.
Yeah, where do you put it?
Exactly. It's so often just relegated to a salvage therapy role.
Yeah.
It's the drug you pull off the shelf when the TPO-RAs have failed.
Right, rituximab didn't work.
The patient refuses splenectomy, and you're running out of options. It's the break glass in case of emergency drug.
But the question we're asking today, and we're basing this on a whole stack of new data, including the pivotal phase 3 trials, long-term extension studies, and a really fascinating consensus paper from a group of Italian experts, is this: are we using it wrong?
Or, maybe more accurately, are we just using it too late?
Exactly.
And that is really the crux of the whole argument today, because the data we're going to look at suggests that Fostamatinib might actually be a much, much heavier hitter if we just move it up the batting order a bit.
So we're going to look at specific patient profiles where this drug maybe shouldn't be the last resort, but potentially the first switch right after steroids.
It's a big shift in thinking.
And we've got a hook for you today that I promise is going to make you want to stick around until the very end.
Oh, this is a good one.
It's a phenomenon that's been popping up in recent case reports. It's called SROT.
SROT.
Sustained response off treatment.
Which is, let's be honest, it's effectively the holy grail in autoimmunity.
We're talking about patients who take the drug, they go into remission, they stop the drug, and they just stay in remission. But we'll get to that.
We'll circle back.
First, let's set the stage. The landscape of immune thrombocytopenia has changed so drastically. It used to be so simple.
It was steroids, then splenectomy. That was it.
Simple, but brutal.
And now we're in this era of targeted therapy. But the sequencing is the nightmare, isn't it?
It's the big challenge. You've got the TPO-RA, zeltramopag, romiflostim, avocapromopag. You have rituximab, and you have fostamatinib. And the real clinical challenge is figuring out which patient fits which drug and in what order. So let's start with the why. Let's start with the mechanism of action. Because fostamatinib it's fundamentally different from everything else in the toy box.
It really is.
This isn't just another way to squeeze more platelets out of the bone marrow.
Completely different. And this is so crucial for the clinician to understand because the mechanism really dictates who is going to respond.
Okay, so walk us through it. Let's start with the standards.
All right, so let's look at the standard second-line therapies. First, you have the TPO-RAs. What do?
They're the gas pedal.
They're the gas pedal. They bind to the TPO receptor on the megakaryocyte. They stimulate proliferation and differentiation. They don't stop the destruction of platelets.
No.
They just try to outproduce it.
Right. It's like trying to fill a bucket that has a big hole in the bottom by just pouring water in faster and faster.
Perfect analogy.
Eventually, you might keep the water level up, but that hole is still there.
The hole is absolutely still there.
Yeah.
Okay, so then you have rituximab or other immunosuppressants.
Yeah.
They go to the B cells, right? The antibody factories.
So they're trying to stop the antibodies from tagging the platelets in the first place.
Right. They're trying to address the root cause, theoretically.
Yeah.
But it takes time. And it wipes out a pretty significant portion of your adaptive immune system, which has its own consequences.
So where does fostamatinib fit into this whole equation?
Fostamatinib works on the destruction side of the problem, but it works downstream of the antibody production. It is a spleen tyrosine kinase inhibitor, a SYNC inhibitor.
Think SYK.
SYK. And to really get this, you have to picture the macrophage in the spleen. This is the splenic macrophage.
The actual executioner of the platelet.
The executioner, exactly.
Yeah.
So in ITP, you have an autoantibody, an IgG, attached to a platelet.
Okay.
That antibody binds to an Fc gamma receptor on the surface of the macrophage. And that binding event is the trigger. It sends a signal inside the macrophage that basically says, eat this.
And that signal travels via sync.
That is exactly right. Spleen Tyrosine Kinase is the messenger. It creates this whole signal transduction cascade, a series of phosphorylation events that triggers the cytoskeleton of the macrophage to literally reach out and engulf the platelet. It initiates phagocytosis.
And fostamatinib.
Fostamatin gets inside the cell, and it just blocks sync. It shuts it down.
So if I'm using an analogy, the platelet is still tagged. The eat me sign is still taped to its back. The antibody is there.
The antibody's still there.
But the macrophage?
The macrophage is effectively blinded to the sign. Or maybe a better way to put it is, it sees the sign, but the internal machinery that allows it to act on that order is paralyzed.
It can't process the command.
It can't. It inhibits that FC receptor signaling cascade.
I love that distinction. It doesn't stop the tagging, it stops the eating.
That's the one-liner.
Which means, theoretically, it's mechanistically complementary to the TPO-RAs.
That is the key clinical takeaway here. That's
Okay.
the whole point. If you have a patient who is on a TPO-RA and they're producing plenty of platelets, I mean, their marrow is screaming, just churning them out, but they're destroying them instantly in the spleen.
Yeah.
Adding a sync inhibitor addresses the other half of the problem. It is a very, very logical, physiological approach to either combine them or, more commonly, switch between them.
Let's drill down into that physiology just for a moment.
Okay.
So sync is obviously expressed in hematopoietic cells. By inhibiting it, are we affecting anything else besides that one function in the macrophage?
That's a great question, and the answer is yes. Sync is also crucial for B-cell receptor signaling.
Oh, interesting.
So, theoretically, you might be getting a bit of a two-for-one deal. Primarily, you're blocking the Fc-gamma receptor-mediated phagocytosis in the macrophage. That is absolutely the immediate effect that drives the platelet count up. But over time, there is likely some modulation of B-cell activation, which could potentially reduce antibody production down the line. Though I have to say, the clinical data really suggests the macrophage effect is the dominant fast-acting driver of the platelet rise.
Okay, so that's the theory. But as we all know, in hematology, a beautiful theory doesn't always translate to the bedside.
Not even close.
So let's look at the evidence base. We've got the FIT trials. FIT1 and FIT2 were the big registration studies.
Right. These were your classic, randomized, double-blind, placebo-controlled trials. And we have to look really closely at the patient population they enrolled here.
Because these were not easy patients.
Oh, not at all. The median duration of ITP was 8.5 years.
Wow.
These patients had been through the ringer.
So heavily pretreated.
Extremely. Most had already failed steroids, rituximab, and the TPO-RAs. And get this, roughly a third had already had a splenectomy and failed that too.
So this was a true salvage population.
This is the population that keeps you up at night. These are your toughest cases.
And the primary endpoint they used was stable response. This is so important because the definition they used in FIT1 and FIT2 was incredibly strict.
It was much stricter than what we would typically consider a clinical win in practice.
So what was it?
To achieve a stable response, a patient had to maintain a platelet count above 50,000 for at least 4 out of 6 biweekly visits.
Right.
And this was way out between weeks 14 or 24.
And without any rescue therapy?
No rescue therapy allowed.
That is such a high bar. I mean, a single dip, one bad week, and you're officially a non-responder.
You're a non-responder.
Okay.
And honestly, that strict definition is a big part of why this drug has a bit of an image problem.
Because numbers look low.
They do. The stable response rate was 18% for Fostamatinib versus just 2% for placebo.
18%. When a busy clinician hears 18%, they think, why would I even bother?
I know.
It sounds like a coin toss where the coin is heavily weighted against you.
It does. But that 18% number really undersells the drug's potential. Because if you look at a different metric, the overall response, which was defined post hoc
Okay.
as achieving at least one platelet count over 50,000 in the first 12 weeks, that number jumps from 18% to 43%.
Now, 43%, that feels much more in line with what we might accept for a highly refractory patient.
It does. And clinically, let's be realistic. Even if a patient doesn't hit that perfect, beautiful, stable criteria, having their platelets bounce up to safe levels 43% of the time is meaningful.
It's a huge win.
It keeps them out of the ER. It prevents the intracranial hemorrhage. It allows them to have a necessary surgery. In a multi-refractory patient, a bumpy response that keeps them above 30,000 or 50,000 is absolutely a win.
One of the things that really stood out to me in the data was the speed. With this drug, we aren't sitting around for months wondering if it's going to work.
No, it is fast. The median time to response was 15 days.
15. 2 weeks.
2 weeks. And that is incredibly useful clinical information for a physician
Why is that speed so critical in the decision-making matrix?
because it allows you to have a fail-fast strategy. With some other immunomodulators like rituximab, you might be waiting 4 to 8 weeks, maybe longer, to see a peak effect.
Right, and with some of the older immunosuppressants like azathioprine or danazol, you could be waiting for months.
Months, exactly. With fostamatinib, the data shows that 83% of the people who responded did so within 8 weeks.
Okay, so the rule of thumb here is give it a try, but if nothing is happening by week 12 or really by the end of month 3, it's probably not going to happen.
Correct. It gives you a very clear binary decision point. You know quickly. And for a third or fourth line therapy, that's actually a feature, not a bug.
That's a good point. You don't waste the patient's time on a futile therapy, and you don't expose them to prolonged toxicity without any benefit.
Precisely.
So what about durability? We mentioned the FIT3 trial, which was the open label extension. Did the responses stick around?
Yeah, FIT3 was very reassuring on that front. It showed that if you do respond, that response tends to be quite durable. The median duration of response was over 28 months.
Wow, over 2 years.
Over 2 years. So you aren't just buying a patient a few good weeks, you're buying years of remission for those responders. It really seems to be a bimodal distribution. Either it works well and for a long time, or it just doesn't work at all.
And there was a specific subgroup in FIT3 that I think is really relevant for our listeners, the patients who had already failed TPO-RAs.
Yes, this is the most common clinical scenario we all face, right? A patient is on L-Thrombopag or romiplostim, and it either stops working or it never worked well in the first place.
So what happened with those patients?
In the extension study, 34% of patients who had previously failed a TPO-RA achieved a response with fostamatinib.
So a third of them. That validates the mechanism point we made at the beginning.
It absolutely does.
Just because the gas pedal didn't work, that doesn't mean cutting the brake lines won't.
Exactly. It's definitive proof of non-cross resistance. If the marrow stimulation failed, inhibition of splenic sequestration can still salvage the patient.
And just to round all this out, there was a Japanese phase 3 study too, right?
Yes, recently published in the British Journal of Hematology. And it was great because it essentially just replicated the Western data. They found a 36% stable response and a 45% overall response.
So very similar number.
Very similar. It just confirms that the efficacy isn't limited to one specific genetic background or population.
Okay, so the drug works. We've established that. It works in about 43% of these very tough patients, and it works fast. But the big question still remains, when do we use it?
Right.
And this brings us to the Italian expert consensus paper. This paper by Lucchesi, Fatizzo, and their colleagues really challenges the status quo.
This was such a fascinating read for me because it really moves away from that rigid, linear algorithm approach.
Right.
You know, drug A, then drug B, then drug C.
Yeah, the flow chart.
It gets rid of the flow chart and moves toward a patient profile approach.
Yeah.
They argue, and I think they're right, that the one-drug-fits-all strategy is dead.
Yeah.
We need to phenotype our ITP patients.
And in doing so, they identify what we might call the avatar for fostamatinib, the ideal candidate.
Yes.
And the first characteristic they highlight is a big one, high thrombotic risk.
This is a massive point that I think often gets overlooked in the day-to-day hustle of clinic. We focus so much on the bleeding risk of ITP
Of course.
that we sometimes forget the thrombotic risk.
Mm-hmm.
ITP itself is a prothrombotic state. These patients have sticky platelets, circulating microparticles, increased P-selectin expression, chronic inflammation,
And then we come along and we throw TPO-RAs at them.
which have a known, well-documented signal for thrombosis. The incidence is roughly 2 to 4 events per 100 patient years.
And why is that, mechanistically?
If you look at the mechanism, you're driving platelet production to supraphysiologic levels sometimes.
Yeah.
You're potentially increasing blood viscosity or platelet activation. There are plenty of reports of portal vein thrombosis, DVT, PE, and even arterial events like stroke or MI.
But what about fostamatinib? What did the data show there?
This is the key differentiator. In the clinical trials, patients who had significant risk factors for thrombosis, including things like antiphospholipid syndrome positivity or a prior history of a DVT, did not show an increase in thrombotic events compared to the placebo arm.
Okay, that is a crucial piece of information. So if you have an elderly patient sitting in front of you,
Or a patient with a known history of a stroke, or a PE, or uncontrolled atrial fibrillation. In those cases, putting them on a TPO-RA makes me, personally, very nervous.
Yeah, you're always checking their D-dimer. You're worried about that call about leg pain.
All the time. So the Italian experts argue that for these specific patients, fostamatinib should be the preferential choice. It effectively decouples the platelet rise from the thrombotic risk.
That's a really powerful argument. It essentially says, don't just look at the platelet count, look at the patient's comorbidities first.
That's it.
What about the sawtooth patients?
Oh, we all have these patients on TPO-RAs. Their counts swing just wildly. One week they're at 50,000, the next week they're at 800,000, and you're panicking and holding the dose, and then they crash down to 10,000. It's a roller coaster for the patient and for the doctor.
Why does that happen so often with the TPO-RAs?
It's partly due to the complex feedback loop of endogenous TPO levels and the lag time of the marrow response. You pulse the marrow, it overshoots, you pull back on the drug, and then it crashes. It can be very difficult to titrate, especially in highly sensitive patients.
And the Italian group suggests fostamatinib might smooth that right out.
Yes, because you aren't driving production in these artificial pulses. You're putting a constant brake on destruction. It tends to produce a much more stable, flat curve in the patients who respond. So if you have a patient who is just chronically unstable on a TPO-RA, switching the mechanism to sync inhibition can provide that stability.
It flattens the curve, to borrow an old phrase.
Exactly.
Now let's talk about the line of therapy. The drug label generally puts this in the chronic phase, usually after a TPO failure. But there was a post-hoc analysis that looked at second-line use that. It really blew my mind.
This is, I think, the most provocative thought of this entire deep dive.
Yeah.
When they went back and looked at the data for patients who received fostamatinib as a second-line therapy, so immediately after steroids or IDHG failed, before they ever saw a TPO-RA, before rituximab,
Okay.
the overall response rate wasn't 43%.
It was.
It was 78%.
78%. I mean,
Right.
That's a completely different drug.
It's a different drug. That is comparable to, or even better than, what we expect from TPO-RAs or rituximab in the second-line setting.
So it raises this huge question. Is the low response rate we see in the pivotal trials just a function of using it on these burned-out multi-refractory immune systems?
I think that's exactly what it is. When you catch the disease earlier, when the pathophysiology is primarily that clean Fc-mediated phagocytosis, and it's not yet complicated by things like epitope spreading or heavy T-cell involvement, the drug seems to be incredibly effective.
So the Italian experts are essentially arguing that waiting until the patient is multi-refractory just diminishes your return on investment.
That's the argument. If you have a high-risk vascular patient, why force them through a TPO-RA first just to tick a box in an algorithm?
Right. And in the context of avoiding immunosuppression, which is something we all became hypersensitive to during the COVID pandemic, fostamatinib is really attractive.
Absolutely. It doesn't wipe out your B cells for 6 months to a year like rituximab does. It doesn't leave you vulnerable to new infections in the same way. The data suggests it preserves the vaccine response.
Okay, let's pivot to safety, because
Right.
every drug has a cost, right? With chemotherapy, we worry about myelosuppression, neutropenia, sepsis. With fostamatinib, the safety profile it's very distinct. It's not chemo.
It's a unique profile. You don't see significant myelosuppression. Neutropenia is rare and usually mild. The big 3 side effects that you absolutely need to counsel your patient on are diarrhea, hypertension, and liver enzyme elevation.
Okay, let's break them down one by one. Diarrhea. How bad is it really?
It occurred in about 31% of patients in the trials. But the context here is really important. It is almost always mild to moderate. We are not talking about severe C. diff-like colitis or life-threatening dehydration.
And what's the mechanism?
It's thought to be related to some off-target inhibition of CFTR or similar channels in the gut epithelium, leading to a kind of secretory looseness.
So is it manageable?
Very manageable. It's often manageable with simple dietary changes, especially avoiding caffeine or very spicy foods when you're first starting the drug. We always recommend taking the drug with food. That helps significantly. And then, of course, using anti-motility agents like loperamide if you need to. Very rarely leads to drug discontinuation if you manage it proactively.
Okay, manageable. Next up, hypertension. This one affects about 28% of patients. Why does a spleen-focused drug cause high blood pressure?
Yeah, this is likely an off-target effect. So fostamatinib is designed to target sync, but it is a kinase inhibitor, and they're never perfectly clean. It has some mild activity against VEGFR.
Vascular endothelial growth factor receptor.
Right, and inhibition of VEGF signaling is known to decrease nitric oxide production in the endothelium, which causes vasoconstriction and raises blood pressure. It's a known class effect we see with many tyrosine kinase inhibitors used in oncology, like sunitinib or sorafenib.
So as the clinician, what do I do about it?
You monitor BP. It's that simple, especially in the first few months. If the pressure starts to creep up, you treat it with standard antihypertensives. ACE inhibitors, calcium channel blockers, they work just fine. It's usually very responsive.
But you need to be aware of it.
You absolutely have to be aware of it, especially in that elderly patient population with vascular risk that we just identified as being ideal candidates. You don't want to fix their platelets just to give them a hypertensive crisis.
Good point. And the third one, hepatotoxicity, liver enzymes.
Right. ALT elevation occurred in about 11% of patients. The key here is that it's reversible. You monitor LFTs, we recommend monthly at first. If they start to go up, you hold the drug, you let them normalize, and you can often restart at a lower dose without a problem.
So it's not a fulminant liver failure signal?
No, we haven't seen cases that meet Hy's law typically, but it absolutely requires vigilance and monitoring.
Now, this next point is, this is absolutely critical for any prescribing physician, drug interactions. I feel like this is where board's questions come from, but it's also where patient safety really lives.
This is probably the most important practical takeaway for safety. Fostamatinib interacts significantly with statins.
Okay, which ones?
Specifically rosuvastatin and simvastatin.
That's Crestor and Zocor. Very common.
Extremely common. And the pharmacokinetic data shows that fostamatinib increases the AUC, the area under the curve, basically the total drug exposure of rosuvastatin by nearly double, 96%.
Wow.
And it increases simvastatin exposure by 74%.
So if you have a patient on a high dose of rosuvastatin, say 40 milligram, and you start fostamatinib without thinking, you are effectively giving them an 80 milligram dose.
And you're putting them at significant risk for myopathy or even rhabdomyolysis. So the rule is simple. If you start fostamatinib, you must review their medication list. You have to reduce the statin dose, usually by half, or consider switching to a statin that is less affected, like a torvastatin, though even that requires some caution.
And you have to tell the patient to watch for muscle pain.
You have to. It's an easy miss, but it's a very dangerous one.
And it's also metabolized through the CYP3A4 pathway.
Yes, which is the superhighway of drug metabolism.
Yeah.
So strong inducers, like rifampicin, will chew up the drug and make it useless.
Strong inhibitors.
Strong inhibitors like Ketoconazole will skyrocket the drug levels and increase the risk of all the toxicities we just talked about. You have to put on your pharmacist hat for a minute when you prescribe this drug.
Absolutely. Okay, let's move into the special contexts. We touched on COVID-19 briefly when we were talking about immunosuppression. But fostamatinib actually had its own moment in the COVID spotlight, didn't it?
It did. There's a very strong theoretical rationale for using it. The thinking was that sync inhibition blocks FC receptor activation, but it also dampens other inflammatory pathways like C-type lectin receptors.
So the theory was it could stop the cytokine storm.
Exactly. Stop the cytokine storm and maybe even netosis, that's neutrophil extracellular traps, which we know drives severe COVID pneumonia and microthrombosis.
A very cool idea. What did the data show?
Well, it's mixed. There was an early smaller study by Stritch and colleagues that looked very promising. It showed fewer days on oxygen, better outcomes in critical patients. But then the larger randomized trial, which was published in JAMA Network, opened by Collins et al., it was a bit of a letdown in terms of efficacy.
It showed no significant increase in oxygen-free days compared to placebo.
Correct. It didn't meet that primary efficacy endpoint, especially in the Omicron era where the disease had changed. However, and this is the key takeaway for the hematologist, the safety data in those trials was solid.
Meaning what?
Meaning that using fostamatinib in a patient who has active COVID or is at high risk of getting it does not seem to make the infection worse. In fact, it might even help dampen some of that inflammatory response, even if it's not a cure for the virus itself.
And crucially, unlike rituximab, it doesn't impair the vaccine response.
That's the big one. Your patient can still mount a good antibody response to a booster shot. In the current viral landscape we live in, that is a major point in fostamatinib's favor.
Let's talk about another special context. Warm antibody autoimmune hemolytic anemia, or WAIIAA.
Yes, the sister disease to ITP. It's the exact same mechanism, just a different target cell. The macrophages are eating red cells instead of platelets.
So is the drug approved for this?
Not yet. Fostamatinib is not FDA approved for WAIIHA. But the data is very intriguing. The phase 2 data showed a 46% response rate.
That's very good.
That's extremely good for a disease where we have almost no approved therapies and we rely so heavily on steroids and rituximab, which don't always work.
But then, phase 3 happened, the forward study.
The forward study.
Yeah.
It technically failed as primary endpoint.
Yeah.
But this is a classic case of the devil is in the details. The failure was driven almost entirely by a massive, and I mean massive, placebo response rate in the Eastern European trial sites.
What happened there? Any idea?
It's not entirely clear. It could be differences in the standard of care, maybe different patient selection, maybe the background steroid tapering protocols were managed differently. But when they did a pre-specified analysis of just the Western region, North America, Australia, Western Europe, the drug showed a significant benefit with numbers very similar to the phase 2 data.
So for the listener, if you have that patient with refractory WAIHA who has failed everything else,
It is a very reasonable off-label consideration, provided you can get compassionate use access or something similar. The mechanism makes perfect biologic sense. The macrophages in the spleen are eating the red cells via the exact same sync pathway. If it works for platelets, it should work for red cells, and the Western data supports that efficacy.
Okay, now for the hook. The thing we promised at the very beginning. Let's talk about the SRO-TIBA phenomenon.
Yes.
Sustained response off treatment. This comes from a case series by Ganema and colleagues. Tell us about these patients.
This is the kind of paper that, just gives you goosebumps as a researcher or a clinician. They reported on 4 cases, and these were not your average patients.
No.
These were highly, highly refractory. They had failed steroids, failed TPO-RAs, failed rituximab, some had failed splenectomy. These were the nothing works patients.
The nightmare consults.
The absolute nightmare consults. So they were put on Fostamatinib, and they responded. Their platelets normalized. And then, for various reasons, some had side effects, some it was patient preference, they tapered off and stopped the drug.
And usually with a TPO-RA, you stop the drug and the count just crashes.
Within a week, you're back to baseline. But with these 4 patients, the counts stayed normal.
For how long?
Months went by. Years went by. One of the patients has been in a durable remission for over 2 years now without any therapy at all.
That sounds like, I'm afraid to say the word, but that sounds like a cure.
We have to be so careful with the C word in autoimmunity, right?
Yeah.
But it looks like a functional cure. The speculation about why is just fascinating. Does sync inhibition somehow reset immune tolerance?
It's not just blinding the macrophage anymore. Maybe it's actually retraining the whole system.
That's the theory. Or perhaps by breaking that vicious cycle of destruction and antigen presentation. You have to remember, after macrophages eat the antibody-coated platelets, they present those platelet antigens to T cells.
Right, which perpetuates the immune response.
It perpetuates the whole thing. So maybe by stopping that initial eating step, you stop the antigen presentation, you allow the whole immune system to just cool down, you interrupt epitope spreading. It's all speculative, of course, but it suggests true disease modification.
Something you just don't see with TPO-RAs.
Never. When you stop Promacta, the platelets drop. This SROT phenomenon suggests Fostamatinib might be doing something much deeper to the underlying disease process.
But it's rare, right? We shouldn't be promising this to our patients.
Oh, absolutely not.
Oh,
it's very rare based on what we know now. But the fact that it happens at all, especially in these incredibly refractory cases, is significant. It changes the conversation from just palliative management of a chronic disease to the potential for remission induction.
That's a paradigm shift.
It really is.
Okay, let's get practical before we close out. Dosing and administration, super simple. How do I rate the script?
Standard starting dose is 100 milligrams BID, twice a day.
With or without food, what's the recommendation?
The recommendation is with food. It definitely improves the GI tolerability, especially the diarrhea. Technically, the bioavailability isn't strictly food dependent, but for the patient's gut, taking it with food really helps.
And what about titration?
You check a CBC at week 4. If the platelet count hasn't reached 50,000 or isn't on a clear upward trajectory, you increase the dose to 150 milligrams BID. And that's the max dose.
And the stopping rule. This seems important.
Very important. If they have not had a clinically meaningful response by 12 weeks, you stop the drug.
Don't drag it out.
Don't drag it out. It is not going to magically kick in at month 6, by month 3.
And monitoring, what's the routine?
CBC, blood pressure, and LFTs, your liver function tests. Monthly is the standard cadence until a patient is stable on a dose, then you can potentially space it out. But definitely monthly for the first 3 to 6 months.
Simple enough. Okay, so let's wrap this all up. We've done a very deep dive into the mechanism, the data, the safety, the special cases. What is the final synthesis here? Where does this drug fit?
I think Fostamatinib fills a specific and absolutely vital niche in our toolkit. It's the non-immunosuppressive, non-thrombogenic option.
So it's ideal for that active elderly patient with cardiovascular risk factors.
Exactly. And it is the most logical next step for the patient who fails a TPO-RA.
Because it offers that completely distinct mechanism blocking destruction that complements the other drugs we use, which are mostly focused on production.
Right. And if we really take that Italian expert consensus paper and the second-line data to heart, we have to ask ourselves the hard question, are we waiting too long to use it?
And that's the provocative thought I really want to leave our listeners with today. The drug label says chronic, and the pivotal trials showed an 18% stable response rate in that heavily pretreated salvage population.
I see.
But that post hoc analysis showed a 78% response rate in the second-line setting.
The enormous discrepancy between those two numbers, that is the gap in our current clinical practice. It suggests we might be, burning the village down with other therapies before we send in the one that could have put out the fire in the first place.
So the call to action is this. The next time you have an ITP patient sitting in front of you, maybe they have a cardiac stent, maybe they have AFib, or maybe they're just sick and tired of the ups and downs of their TPO-RA, really evaluate if sync inhibition is the missing key.
It might just be the best second move you can make.
Thank you so much for joining us on this deep dive. We really hope this helps you navigate your next difficult ITP case.
And keep questioning the algorithm.
See you next time.